All right, I think in the interest of time, I'll start. Good morning, everyone. So the topic for this talk is management of Waldenstrom Macroglobulinemia. For many of us, it's unusual. It's an unusual plasma cell disorder, but we see enough patients at Mayo to make a separate talk for this. And a lot has happened over the past few years. So these are my disclosures. I would start off with a case of a 42-year-old lady who presented to the emergency room with a 2-week history of fatigue, dyspnea on exertion, productive cough, and fever. And CBC, interestingly, showed a hemoglobin of 5.9. It was normocytic anemia. Platelet count was normal. White count was slightly elevated with 10% bands, and she denied any history of bleeding. There was no visual disturbance, headache, changes in her mentation. The ER physician ordered a peripheral smear, which gave him a good clue. There was evidence of rouleau, and the M spike was subsequently checked through serum protein electrophoresis, and it revealed an M spike of 3.2. And immunofixation showed that it was IgM kappa. On physical examination, there was mild splenomegaly. And this is, as you can see, there's clear evidence of pneumonia with air bronchogram on the CT. Other tests included urine protein electrophoresis, which showed a 5 gram of proteinuria, or I should say 6.8 grams of proteinuria, 5 grams of which was monoclonal. The IgM level was high. It was kappa type. Viscosity was 1.5. There was no evidence of cryoglobulin. Cold agglutinin screen showed a small titer, and the haptoglobin was high, an acute phase reactant in this case, and also ruling out hemolysis. LDH was within normal range, and beta-2 microglobulin was 3.3. So this was actually a classic case of Waldenstrom macroglobulinemia that presented with an infection and anemia. So there are some controversies associated with the definition of Waldenstrom.